I'm June Simmons with Partners in Care Foundation, which is in Los Angeles. So I'm proud to have this opportunity to serve as a social work voice as part of this broad population. These issues cross-cut ages, income, ethnicity. It's universal, and I'm pleased to speak to what we think is a missing specialty in the integrated model. We're talking, the title is integrating with healthcare. So if we're integrating with healthcare, social services, and it's specifically alternative workforce is a blend of people who are highly educated and a blend of other people who are also very talented and important in engaging with people. How do we change these? There's a remote right here. Ah, that it? What? This is good. This is good. You can see it's a broadcasm. It's a big job to get from one side to the other for an integrated system, but you can see that some people have made it. When we found this graphic, nobody was on the other side, so we added them because we are the pioneers that are together bringing these new solutions. And we think it's very, very important then to look at the social and behavioral determinants of health. And we're really excited that those have arrived as an abbreviation. They have achieved recognition, as we see here, because several of us here were on the Dying in America wonderful work group, and now you've broadened this to more seriously incorporate these components. So we want to look at, yes, thank you. Yes, please, thank you. Now you've all seen this, I know, this important. What we did was pull it apart to try to highlight behavioral patterns, because we've been hearing these wonderful presentations about what happens to people's lives. If they're alone, it's serious, and if they have caregivers, it's serious for the caregivers and sometimes for the person, as Kathy Greenlee pointed out. This huge factor, because as we talk about social determinants, we hear a lot about housing, a lot about food, a lot about transportation, all of which are critical. But we're very interested in resourcing people who are up against these challenges. And as we could hear, medicine is a very complex, fragmented system that's hard to navigate, and so is the community. So the model I want to speak to is what happens if we bring an alternative workforce, because you can't go to the home if there's no skilled need unless we change the system. Home health can go if there's a skilled need, but they're there briefly. So this is a whole different approach to the delivery system that goes out to see the kinds of complications, the kinds of things that go wrong, the kinds of confusions and obstacles that people face that we can't really imagine when they're in the office or in the hospital nodding that everything's fine and don't worry, we can take care of ourselves. So we want to point out that there's a range of human beings, whether they're promotorists or whether they're community health workers, coaches, social workers, that the community-based organization, CBO is community-based organization, can serve as the eyes and ears in the home for the team. Even PACE, and I love the PACE model, and I agree with you. In fact, the PACE model is an illustration because it was launched by Unlock when you were saying you've been at this 30 years, people have been declaring their longevity in this, and I have quite a bit myself in this process. PACE was launched, and you see how long it takes. So this is a big chasm, but we're ready now. So we think that these eyes and ears in the home entering the formal delivery system and being formed as a regional delivery system of its own that integrates, that community-based organizations are critical players that need to have their place in the sun and are organizing themselves, as you will see, into formal partners for the healthcare system. bringing accreditation, bringing evidence-based programs, and addressing how do we equip people with both resources and the ability to change their own behaviors in order to get better health outcomes. So we think that community-based organizations, oh, did we skip one? Are the bridge to the home. And bring a great deal of natural experience. They are local. They're grounded in all the resources because, you know, we have some risks as we go to reorganize that we may start paying for things that really should come from love and neighborly spirit. And we do not want to root out people caring for each other, but we also don't want to have only that as we shortened hospital stay and gave people a lot of other roles. But this is a very unique workforce that can bring a lot of localness, a lot of cultural and linguistic capabilities, very important. So a system like that, we're working at the national level with under the Administration on Community Living and the National Association of Area Agencies on Aging with John A. Hartford Foundation funding, SCAN, and more, West, number of foundations joining together, and trying to build out then consistent evidence-based approaches that would be ways to go at this. So for population health management, we need to look at people with multiple chronic conditions, people who have an episode of care, in the second one to the right, and the long-term supports and services, and have consistent, thoughtful, and often brief, except for long-term supports and services. These other can be brief interventions that enhance the skills and resources of individuals up against health issues. So, good. So we'll want to think about success, and one will be that we actually get, you know, people do go to the health system, the healthcare system. Can that system learn to identify and connect people with these resources? Can these systems of community agencies bring sustainable, high-yield, focused interventions that target the right people in the right way? So targeting is critical. We can't do everything for everyone, but we can't do nothing and let things then result in avoidable suffering and avoidable costs. So these are critical. So then we know we have to have metrics for success, and Dr. Lin wishes I had random controlled trials that would bring you more evidence, but we have solid, deep proof of success in multiple settings across this country with these kinds of partnerships. And so I thought I'd give you one of those partnerships as an example. We've been working with UCLA as one. I should mention the CCTP, the Community Care Transitions Program, had a lot of success that Dr. Lin identified. CMS kind of ignored that, but we have deep proof of track record of success. So that led to some partnerships at UCLA, which is an elegant site. So we thought, well, we'd just see what does a partnership look like. So in this instance, or we could have used our partnership with the Providence Health System or medical groups, whoever it might be, UCLA, they become, in this instance, the payer because they carry the risk for hospitalization. This is a care transitions program. So whoever is going to get the savings, that's who's going to pay. In our fragmented American system, that makes it a lot harder, but that's where we have to go. And so we have a number of years there where we've seen over 8,000 people, and the system has developed a way to automate identifying who is at risk of readmission and immediately get them to an on-site coach who connects them to a brief Coleman and Bridge set of interventions to reduce readmissions coupled with an evidence-based medications tool that a non-clinician can use to bring to pharmacy and physician or nurse practitioner the truth about the meds at home. Because going to the home, one of the most critical elements, it's a bridge between the two, is figuring out what in the heck is going on with meds in the home. It's shocking, and it's a high prevalence rate. We have a recent study that's going to be published that showed of the high-risk people coming out of a hospital with a matched population, that of those that were served by a CBO, 99% had meds that needed to be reported to the physician. Typically, we think it's 60 or 70, but in this case, it went to an integrated practice-based pharmacist, and so they'll really find this. So this is number one driver of readmissions and inappropriate admissions and ER. So these, using the LACE criteria, took us to some very nice results over a period of time that showed a high risk of readmit population that would typically have a 27% readmit rate when the community-based organization coach went to the home once, did a full assessment, got the meds, and addressed some of the issues in a 30-day intervention, 2/3 reduction in readmission. So this is not isolated, but it's spectacularly good. So we thought it was a nice example that there are significant changes in ongoing healthcare that come from finding the meds, helping to stabilize the person, getting them in for their follow-up care, and it's brief, so it's affordable, sustainable. The ROI is great. And if you look at population health, it was a 3% population-wide impact, according to UCLA. So they decided to keep them on. So now's the time. We see the possibility that we can move this agenda forward together. We have heard about the new rules. We hear that we got to call Burma because we got to clear the barriers for PACE. But we hear about the Chronic Care Act. We see the supplemental Medicare Advantage benefit and the special needs plans for the first time opening to a subset benefit for high-risk people that opens the door to these other determinants of health, the self-management, other risks that people can address. What's the solution to that? My opinion, I'm hopeful. I see the National Academy stepping up for this. We need to help lead the industries to define what would be the next generation that would give models for this supplemental benefit. Those plans are afraid that we don't want them to do too much or too little. We want Goldilocks. We want the just right benefit that yields significant health changes and is sustainable, that's economically responsible, that it's culturally and linguistically sensible, that it takes into account the elder abuse risks. So we know we have to build, oh, I'm sorry, we didn't change the slide. There we go. So we can see this in the states as well with duals waivers, with other Medicaid programs, with a whole array of opportunities to look short and long term. And we can see out of the Administration of Community Living, several decades of leadership, a whole platform of evidence-based self-management program resources built out across this country that medicine is not taking advantage of and not partnering with. So these are very important. Got it? Good. Okay, so it's a national movement. It's been in force for some time. ACL really helped lead this, has made investment. The John A. Hartford Foundation has been a powerful investor and led, and the SCAN Foundation, to bring groups together across this country to really look at how to build integrated regional delivery systems of home and community-based services for short and longer-term interventions that will be accessible, because a health plan, a doctor, a hospital, they just can't take their people and run them out once in a while to the home. They need a system of care. And they can't stay out of the office and still be in the office. So we need delivery systems, and they need to cover the service area that those folks are trying to serve. And so statewide delivery systems have emerged across America and are available through the Aging and Disability Business Institute and other groups, trailblazers like us, that are working together, again, under John A. Hartford and SCAN, and a cluster of foundation and government investors, to build these out and to partner with all of you in your areas to really move this forward. So thank you for letting me carry on about this passion in my heart, and to look forward to discussion as we move forward.